Thanks so much for joining us today. My name is Tim Cooper, and I'm on staff here with North Point Ministries, and I am excited about the opportunity that we have today to learn from some experts on a topic that impacts all of us. One of the best parts of serving at a church is also one of the most challenging parts, and that's the reality that God brings us all kinds of people. Now, whether you're a volunteer or you're on staff at the church, it's our job as a church to help equip you to interact with all the different people that come your way. What most of us might not realize is that 1 in 5 adults have been diagnosed with a mental illness of some sorts. And because of that, we want you to feel equipped and prepared. So we have decided to bring in 3 experts that can help us identify mental illness, welcome these individuals with mental illness into our church, and provide them with great next steps. But before we get there, I want to introduce our experts to you. First off is psychiatrist Dr. Michael Liles. He is a board-certified psychiatrist who has delivered care and provided clinical leadership for over 30 years in public, correctional, academic, and private settings. He has published over 100 articles, book chapters, and videos that are designed to increase the recognition of and treatment of psychiatric disorders, especially in the communities of faith. He has served as a consultant to pharmaceutical, professional, sports, and religious entities. He is married with 3 adult children. Next up is Kim McMillan, a licensed professional counselor that specializes in mental illness, who received a Master's of Arts in Professional Counseling from Richmond Graduate University and a Bachelor in Science in Christian Counseling and Care from Oral Roberts University. With a background that encompasses over 10 years of counseling in a broad range of issues, at present, Kim works in a concentrated area working with major depression, bipolar disorder, anxiety and stress disorders, anger management, healing of the inner child, and spiritual formation. And finally, we have David Smith, who has an MDiv and is also a licensed professional counselor. He has served as the executive director of the Summit Counseling Center since January 2001. David is both an ordained minister and a licensed therapist who has served as a pastoral counselor, a psychiatric chaplain, and as a marriage and family therapist since 1989. He specializes in working with couples and with people who have experienced trauma. Thank you all 3 for joining us today. So Kim, I think it's really important for all of us today to be on the same page with mental illness, and it seems like mental illness could mean a lot of different things to a lot of different people. So could you kind of give us a foundation to work from, or a definition that you would be most comfortable with?
Yes. According to NAMI, the National Alliance on Mental Illness, mental illness is a medical condition of the brain that disrupts thought processes, mood, as well as functioning, ability to cope, and also relationships. The way they relate to God, the way they relate to themselves and others. Mental illness affects all of these areas.
So David, what would you say for today's purpose, what would be classified as a mental illness?
Things like major depression, schizophrenia, bipolar disorder, and borderline personality disorder.
So Dr. Liles, could you just give us a snapshot of each of these so we can maybe better understand each of these categories?
Let's begin with depression, what we call major depressive disorder, because this is the one that most people have known of someone that has this problem, or someone in their family or in their church. And here you have people who are dealing with pervasive symptoms of sadness, feeling down, low, blue, in a consistent basis, and in a way that impacts their lives. They have trouble sleeping, they tend to wake up in the middle of the night, they have trouble with their appetite. So it's a sense of sadness that's affecting them physically. It affects their perception, so that they see things as very negative, very hopeless. People always talk about, do you see a glass as being half full or half empty? The depressed person sees the fingerprints on the glass. They never make it to the half full. They may have trouble losing interest in things that are fun or pleasurable. This is the person who disappears and doesn't come to Bible study anymore, who's isolating from people, crying easily, and can also become so down, so out of it that they become suicidal. So you have someone here with severe periods of depression. In contrast, we have someone, bipolar disorder, which most people, when they think of bipolar disorder, they think of someone who's manic. Actually, most of the symptom time that people are sick with bipolar disorder, they're depressed. They have way more trouble with depression. But the thing that contrasts it with major depressive disorder is the manic episode. The person here, in the words of one of my patients, they feel as if they have electricity for blood instead of blood. They're very fast if they're talking, if they're walking, they don't sleep. They drive fast, they spend money impulsively, they may get hyper-religious. Everything is very hyped up and on like warp drive on Star Trek. And this can go on for weeks on end and cause tremendous problems in the person's life. I had a patient spend their child's college fund in one weekend during a manic episode. So you have bipolar disorder in contrast with depression. Borderline personality disorder kind of looks a little bit like bipolar disorder in that the person can have mood swings and mood instability like you see with bipolar disorder, but it's to a much lesser degree. The key word with borderline personality disorder is intensity. These are people who are very intense in how they relate to people. You're either my best friend or you don't exist. They love you one day and they drop you the next day. They can get depression and have suicidal thoughts, may even cut or mutilate just like people do who have major depressive disorder, but the moods fluctuate to a great deal. They tend to have very unstable patterns of jobs, relationships, involvements. Then you have schizophrenia, which is the one that people traditionally think of when they think of psychiatry. These are people who are having trouble with perception of reality. They may have hallucinations where they hear things. They may have delusions where they feel that someone is following them or someone's out to get them, in other words, paranoid. But they've lost a sense of reality, a sense of contact with reality. And those are the ones you see in all the old movies about psychiatry in state hospitals, and represents maybe about 1.5% of the people that we actually work with in the field.
So David, with mental illness, I would hope the church would be maybe the first place people would think to go to get help or to find as a safe place, but I don't know if that's the case across the country. What have you seen in relation to how people with mental illness feel about going to the church?
So for people who've had a positive experience with the church, they often turn to faith leaders and church leaders first as a beginning point for seeking help, and they anticipate that they'll be welcomed. But for people that are not churched, or for people who haven't had a positive experience through church, recent research shows that 55% of those people assume that the church will not be welcoming, that it won't be a place to turn for help.
So Kim, one of the things that I think everybody watching this would want to know, it's one of the things that I would really want to know is, how is somebody's relationship with God affected because of mental illness?
Sure. You know, there's numerous ways people's relationship with God is affected. On a more positive side, I often hear in my office people report to me that their relationship with God is actually strengthened simply because of their dependence on God and the hope that they receive through their relationship with God just to make through each and every day. Of course, on the other hand, when people are not diagnosed and treated, or if in fact their illness is not well managed, or for example, if they're having maybe breakthrough symptoms, their relationship with God could take a different turn. Some other things that can happen in regards to mental illness and relationship with God is, again, in the way that people are relating to God Himself. Oftentimes people do lose pleasure and interest in things normally enjoyed. So they may find that they're not attending church as often, they're not attending life group or Bible study, they're not in prayer as often as they usually are. Also, some of the things that can happen is perception can get distorted. And when this is happening, it leads sometimes to severe sense and feelings of failure, worthlessness, hopelessness, perverse guilt and shame. And obviously these kinds of things can create extreme barriers sometimes in people relating to God. On the other hand, it's important for us to remember that when people's illnesses are well managed, and mental illness can be managed and medicated and treated, a lot of times these types of symptoms can dissipate or even be eliminated so that people can fully enjoy their relationship with God, their relationship with the church and fellowship, and live out the full potential of who they are in Christ.
That's so true, Kim. One of the things I've observed in my practice is that so many Christians suffer alone. One of the things in working with my patients that causes me great pain, I might add, oftentimes I will ask someone, and I'm talking about people who are evangelical Christians, and they're dealing with anxiety or depression or mood swings. Are you a member of a local church? Yes. Have you told anybody in your church what you're going through? No. Do you feel safe telling someone in your church what you're going through? I'm not sure. If you were to share this with someone in your small group, what would happen? I don't want to find out. So what ends up happening is that a lot of people that are struggling with mental, and this is really important. If there's one thing I'd want to say on this whole video, it'd be this. A lot of people with mental illness, Christians, are struggling alone, in isolation. They're not telling anybody about it except folks like us. And it is shocking to me how alone, I saw someone today, how alone these folks are in their struggles, how alone their families are. At the end of the day, I take my list of patients home, and what I'm supposed to do, and I try to do, is pray for them. Because sometimes they tell me things they haven't told anyone. They're afraid to tell anyone else. I think that the mentally ill, when you consider that 1 out of 5 people in this country are suffering of some kind of mental illness of varying degrees, it is a huge evangelistic and discipleship opportunity that the church is allowing to slip through our fingers by not owning the fact that we have people in our congregations that are struggling with issues, and they need us to be actively involved with them and not just telling them to stop it.
Mental illness is such a disruption. No one wants to be mentally ill, and most people experience it as this intrusive experience. And in the midst of that, their thoughts are interrupted, their feelings are interrupted, and their relationships are interrupted. And so often they experience that same experience of interruption with their relationship with God. So people are often finding that they can't feel close to God. Thoughts and feelings and beliefs that typically were their bedrock before feel disrupted or dislodged or kind of moved, hard to find. And so for a period of time, there's a kind of leap of faith that they almost feel like they have to take, that I know I'm not going to feel close to God right now, or I know that I'm not going to be able to grab hold of the beliefs and feel them to be true that I've always felt before. However, I'm going to still hold on to those things despite what my feelings and my thoughts are telling me.
So Dr. Lyles, it would seem that a lot of Christians think that maybe prayer and Bible study alone could maybe cure mental illness or really help heal mental illness. What would you say to people that are kind of coming from that mindset?
I think one of the reasons that so many of my patients kind of stay in the closet about what they're going through is because they have already found the results of many of the studies that are out there showing that a little less than half of the Christians in churches believe that if you pray right and study the Bible appropriately, you really shouldn't have these problems. It should treat mental illness compared to about 27% of people in the community at large that are not Christians. I remember when I went into psychiatry, I was involved with a parachurch organization at the time, and I announced to all of my friends that I was going into psychiatry, and one of my mentors that was discipling me told me he was very disappointed in me that I would be casting my pearls before swine to go into psychiatry, because if people really knew Jesus, prayed right, and studied their Bibles, they would never have these problems. Can you imagine what that does to someone who prays right, studies their Bible, and they're still having these problems? Many of my patients, I think, suffer in silence and try to keep what they're going through a secret because they've already experienced some of what the research has shown, because basically a little bit less than half of Christians, about 48%, do believe that if you were to pray appropriately and study the Bible appropriately, that you would not have these problems, compared to about 27% of people out in the community at large.
I think part of the reason we have this perception among Christians is because we all know how helpful prayer and Bible study and fellowship can be, but we're comparing our normal experience to someone's experience in the midst of mental illness.
I think one of the reasons that happens is because of what you said earlier about this being a brain disease. I think many people don't think of it as a disease of the brain. They think of it as a spiritual issue, thus a spiritual treatment. when the brain is an organ like other organs in the body and would be susceptible to stress, infection, trauma, medications, hormones, all kinds of things that would affect how we perceive things, feel, interact with people. The symptoms don't always necessarily tell you about the cause. And a lot of times we assume that because we don't think of the brain in the way that we would think of a heart or a kidney as an organ in the body.
That's good.
So I mentioned in the beginning that 1 in 5 adults currently in the United States are diagnosed with some sort of mental illness. And David, currently it would seem like the church might be the last place where they would feel welcome. How do we go about fixing that problem?
One of the first ways that we can make people feel more welcome who might be suffering from a mental illness is that for our faith leaders to talk about their own issues with mental illness or other struggles from the pulpit. So hearing Andy Stanley or another pastor talk about that and their own experiences from the pulpit makes this less stigmatized.
Yeah. I was just going to add, many times when we're authentic and real and we offer our own experience, as David's saying, that kind of paves the way for others to also do the same and feel more comfortable when we get into fellowship. They feel normalized in that way.
So how can we, as staff at a church or as leaders at a church, how can we raise awareness for mental illness?
I think that the training that is occurring at this moment is a fantastic way of raising awareness. Education, support groups, possibly even having a mental health awareness week or a campaign to reduce stigma. These types of things are very important and very effective in raising awareness.
I keep hearing stigma and kind of that word associated with mental illness. Can you talk a little about why that's important to remove that?
With the people that I work with, I particularly hear about this a lot with the members of my support group, the bipolar support group that I facilitate. They often have a sense, whether it's perceived or whether it's actually occurring, that they're being judged, they're being thought of as bad people, maybe people that don't hold the same IQ as the next person, and it's this type of stigma. Sometimes they feel that they're being left out and rejected, and it's that type of stigma and judgment that people sometimes feel that we want to make sure they're not feeling when they come to a safe environment like the church.
Once I have a story that just
Please.
follows that greatly. Years ago, I had a patient that sat in my office, was a member of a small group, and said, "You know, Dr. Lyles," and then she started crying. She says, "I wish I was like my small group leader. She doesn't have these kinds of problems. She doesn't feel these insecurities. She doesn't have depression. Her kids are perfect. Her marriage is perfect. Her house is perfect. Her hair is perfect." And she cried and wept and said, "God, why did you make me like this? And why can't I be like my small group leader?" She composed herself. I encouraged her. We got up to leave, walked out into my waiting room, and she goes, "It's her. My next patient was her small group leader." Now, that is a double tragedy, because one tragedy is that she was comparing herself with her small group leader, but to me, the greater tragedy was, why couldn't her small group leader let her know what was really going on? Why was there a lack of authenticity by her small group leader? Right. That's how you begin to work. That's what you were saying. If her small group leader would say, "You know, I don't have it all together. I do struggle," perhaps my patient wouldn't sit there and go through these mental gymnastics.
I really think in terms of trying to help the church be more welcoming, that we really have to think about training church leaders the way that we're doing now and that Kim mentioned. And in the training, it's not important to remember all the checklists and to know all the nomenclature and be able to treat. It's mainly important to get a feel for, this person might be different and I'd like to be welcoming. I'm going to have to do the hard work of looking beyond what my needs are in the fellowship and realize that this person may be at a place in their life right now where they're going to have a hard time reaching out. So I have to help develop strategies to reach in and to provide some support and some bridging and some connection to help them somehow find their way through the maze of how to get connected with church and with fellowship.
I think there's a fear that kind of is associated with mental illness from people that don't have it because it's an unknown. So what are maybe some misconceptions that are common that people make about mental illness? Could we talk about that for a minute?
They're violent, they're irresponsible, they cannot hold any kind of service position in a church. I have had patients that have been excused from teaching Sunday school, involved in children's ministry, asked to leave choir, not felt welcome in their small group once they told folks that they were dealing with depression because of that stigma that this person is dangerous. I don't know what other ones you've heard people say.
I've heard that before as well, and one of the biggest ones that I think I bump into most regularly is the pull up your bootstraps mentality. If you've never struggled with mental illness, it's difficult because a person that's clinically depressed is dealing with an entirely different medical condition that our typical depression, somebody that is just having a bad day, or maybe somebody that's feeling grief. It's an entirely different type of depressive state. And when someone's experiencing that, when they feel like they're getting that message, just pull up your bootstraps and get over it. Again, they feel that stigma once again because they're praying, they're reading their Bible, they're doing everything they know to do to feel better, and yet the illness sometimes just gets the best of them.
A frequent misunderstanding of some of the major mental illnesses that we've been talking about today is that somehow they can be fixed with a single intervention at a single point in time, and that the treatment's going to be fairly quick. And oftentimes people that have been to their family practitioner or an OBGYN and gotten some help for depression, even with a medication, who've experienced rapid results or resolution, compare themselves to people that might have a chronic mental illness. And those people with the chronic mental illnesses are really done a disservice by that, because they often have to manage their mental illness over a lifetime. And they're going to have to learn to think of this as a chronic illness to be managed rather than an illness to be cured.
And I'm thinking specifically with parents on this, but it would seem that parents with kids with mental illness would think it's a result of maybe their poor parenting or maybe some bad decisions they've made. Can you speak to that for just a minute?
I wish it was that simple. When you read the Old Testament, particularly when you read the stories of the kings, you have a good king, sought after the heart of God. Son was horrible. Horrible son, but have a good king. Not a lot of cause and effect. And I always tell my patients that blame themselves that, maybe it had something to do with parenting, that there's only one perfect parent ever in the history of mankind. And he had two kids that rebelled and were rotten, Adam and Eve. How can you blame God for Adam and Eve?
So I've been told that suicide is a symptom of most mental illnesses. Is there a way that we can help in prevention of suicide?
Yes, there is. About 54% of Americans feel that the church does have a responsibility to assist with suicide prevention, and that percentage actually grows higher. Within the church, about 64% of Christians believe that the church has a responsibility with suicide prevention. I recently heard that we lose about one person every 15 minutes to suicide. And to me, that's a staggering number. Some of the things that I think we could do on a more practical level is obviously offer hope, education, and support, as well as train leadership to recognize what are the warning signs for suicide. What are those red flags? What are some of the risk factors for suicide? I think coupling all of those things together would make a big impact in suicide prevention.
I agree, Kim, that we can do a lot to help prevent suicide, including things like offering national screening days at the church. including screening and part of our care and education. Screens often pick up people who might be contemplating suicide, but who haven't talked about it with anybody or who don't fit a typical profile. So being able to allow people the access to questionnaires and screenings and interviews that would capture that is really helpful. It's a great intervention.
So, David, let me ask you, one of the most important things we do at the church, it's the thing that we want for everybody, is to get into a circle, get into a community group. We think that's the best way for them to help take a step in their faith. Can a mentally ill person be a part of a healthy, growing small group?
Well, they already are. Lots of mentally ill people are already members of small groups, and we often have them in our group and don't know it. And if we can make it a safe enough topic to talk about, we'll often find that we'll hear those stories and we can honor those stories. Unfortunately, there are times when people are experiencing a mental illness where they're really in a place where they're destabilized. Their illness is really not being managed and they're not getting the help that they need. And sometimes people in that state are really disruptive to the fellowship of a small group. And at that point, there needs to be typically some sort of group intervention that would involve the group leadership and trusted people within the group to talk with that person on a one-on-one basis and offer support and encouragement, as well as some group boundaries that help that person get the help that they need, but also encourage them to stay connected to the group.
So, Kim, let me ask you, how can we best support somebody that is struggling with mental illness?
My immediate thought with that is to sit down with them and ask them. I think support starts with knowing that person and finding out who they are and what their circumstances are, because support is to every individual as unique as that individual and their circumstances are.
I have an acronym, LOSS, L-O-S-S. Listen to the person. So many of my patients, no one has listened to what they really have to say. They listen to a little bit and they jump to a conclusion like Job's counselors and begin to try to help them without hearing the whole story. Own them. These are not those people, those are our people. I love what you said. They're already in our churches. They're already in our small groups. They are ours. Own them. Serve them. The Good Samaritan was the best example of this. He didn't walk to the other side. He didn't ignore the person in need, but he met their need. And sometimes one of the most loving things that someone has done for one of my patients who was single was come over and fix a meal for her, come over and make her get in the shower. You know, someone from her small group came over and said, come on, we're gonna do your makeup, we're gonna do your hair, I'm gonna cook you a meal, I'm gonna demonstrate my love for you tangibly. She served her in a way that no one had ever done before. And the other thing you said is and along with that is making sure, like the Good Samaritan did, that you make sure the person gets the help that you cannot provide. He took the person to the innkeeper. These folks may need to see a physician or someone, a mental health professional, to help them in a way that the people in their community of faith cannot. But the last S is for stay. Stay with them. The Good Samaritan came back. He didn't refer and leave him. He came back. And if you're going to do what you were talking about, I like what you said when you said if you're going to kind of do an intervention to get them to get some help, please stay with them. I've had far too many patients who were abandoned by the people who should have been there with them through the process. So LOSS represents listening to the people, owning them. They are ours. These are our people. We're the same body of Christ. Own them. They're not somebody else's problem. Serve them and stay with them.
So, David, how does a leader know if they can work with the person that has mental illness or if they should be referred to a professional and maybe both? How do they know kind of healthy boundaries around those two?
One way to decide if you can be the best person to help is to get some additional ministry support yourself and to reach out to those other ministry leaders that are around you and use them for consultation and supervision to talk through this experience with them. But some things that are important to recognize, if the care receiver is really overwhelmed, if their symptoms are acute and severe, it may be time to go ahead and make a referral and help them get the help that they need. Or if their symptoms are chronic and they're really not remitting, they're not really getting relief after a significant period of time, it's important to make sure that as a ministry leader, you're making sure that they're bridged and connected to a professional in the community. And if that person trusts you and your ministry relationship, you may be able to get them to sign a release that would allow you to be a part of their treatment, be a part of the discussion, be a part of the community that supports them. Finally, if the person is overwhelming you as a ministry leader, that might be a good sign that it's time to go ahead and make a referral and even find someone else within the ministry who might feel more comfortable working with this person.
Referrals might also be made at times if someone is suspected to have suicidal or homicidal type of ideation. That might again be a red flag or a warning sign that a referral to a professional would be needed.
Another important thing to think about is whether or not substance abuse or addiction is involved in the mental illness. A lot of people who suffer from one of these major mental illnesses frequently self-medicate with alcohol or other drugs. And it's so important to make sure that that's addressed as well, and that a person who's actively abusing substances is getting the help that they need with that, and getting challenged to be aware of how that's impacting their mental health.
The whole issue of substance abuse we haven't even touched on. I'm glad you brought that up, because in church settings many people assume that that's not happening here, that those people were still hung over from Saturday night. They're not at church on Sunday. But the way addiction looks in the church, you get the usual stereotypes of people using alcohol and drugs, but prescription drug abuse is what we're good at in churches. Pain pills and other things that are addictive and mood altering that people don't think of as addictive because they've received from a physician, but still causing problems akin to what you're referring to.
Absolutely.
So Dr. Lyles, what is the best thing we can do for those with mental illness?
In other words, what does treatment look like?
Yes.
For many of the kinds of problems that we're talking about, one component of treatment would be medication. That's something that people think about a lot when they think about what we do with people with mental illness. There are many other things we need to do, but medication is sometimes something that's necessary for people who are bipolar, people who are depressed, people who are having severe mental illness.
So one of the concerns, it seems like, is, especially with family members and loved ones, is will this medication change their personality? Can you speak to that?
Their illness has changed their personality. A lot of times when patients talk to me about taking medication, the whole focus is on what will this medication do to me, without any discussion whatsoever of what the untreated illness has done to them and their personality and their relationships. All we really are trying to do is help them become who they really are without the distortions of all of the psychiatric issues that are making them act like someone that's out of character for them, emotionally, psychologically, and spiritually. And so in some respects, I do want the medication to change them so that they become the person that can relate to God, like you were talking about before, and relate to their families appropriately.
So Kim, besides medication, what are some other treatments that we can do to help people with mental illness?
Sure. Well, for severe mental illness like we're talking about today, medication is certainly the cornerstone of treatment. But alongside medication, it's very important that people receive individual counseling, family counseling, group counseling. Nutrition is very important for brain health, as well as exercise. Another thing that I like to say is king alongside of medication is routine. Many of us would just not think a lot about routine, but for people that are struggling with mental illness, routine is very important, particularly sleep. It's very important to get an appropriate amount of sleep and to have a regular bedtime, a regular wake time, and have what we call a social rhythm through the day, where there's a routine throughout the day as well.
When we think of treatments, it's so important to remember that wedding medication with talk therapy is so important, because either one by itself might have some positive effect, but the two together have been shown over and over in outcome studies to be the treatment that's needed, so that you get both those, the biological help as well as the relationships and the change in thinking, the change in feelings, and addressing lots of other things through talk therapy.
So David, everybody listening to this, they really want to help somebody that they're walking through this even discovery process or treatment and helping healing in this relationship. Can you tell us more about what that care receiving and caregiving relationship looks like?
Well, the caregiving and care receiving relationship is really a balancing act. So on the one hand, the care giver really wants to make sure that the person receiving the care understands that they're willing to maintain the relationship, that they want to be there for them, that they want to spiritually support them. And yet at the same time, they have to establish some healthy boundaries. The care giver cannot allow the care receiver to monopolize their time and to make unreasonable demands about them that would violate the kinds of healthy boundaries that we would assume would be in place for Christian relationships. Mm-hmm. And at the same time, there might be some care receivers who, as they began to move further into their treatment process, might be appreciative for the referral, but who might not want to share everything about what's happening in that relationship. Mm-hmm. They may not want to talk about the details of what happened in their psychiatric or their counseling visit. And it's important to recognize their right to kind of maintain that privacy and that boundary. So in some ways, this is a balancing act.
Yeah. People who are diagnosed with borderline personality disorder, for example, boundaries is a big part of the therapeutic process for that particular disorder. And in doing so, healthy boundaries, interacting with that person with healthy boundaries is a teaching moment for that individual and is therapeutic as well.
Well, David, all of this is so helpful and so insightful. If you could leave our leaders with one thing today, what would you want to tell them?
I think one of the most important things in trying to help mentally ill people feel welcome at the church and to feel connected is to not forget their families. Oftentimes the key to reaching and keeping the mentally ill person is their family. Their families, according to recent studies, are suffering 2 to 3 times the typical stress that other people suffer. They're often feeling isolated just as much as the mentally ill person. And they are often really pressed to find resources. So they are looking for solutions, they're looking for friendships, they're looking for support. One way of supporting those families would be to gather families like that within the church as a group and allow them to teach ministry leaders as well as one another what solutions have worked and which things have been tried that haven't worked that we need to do a better job of as a church.
So the one thing that I would want leaders to remember is, again, that mental illness is a medical condition of the brain, and to conceptualize mental illness in this way allows us to approach that population of people in such a way that we are genuinely able to give them the care and the love, the acceptance and the validation that everyone's looking for, but especially people that are suffering with these types of symptoms.
What I would want to add is that the Great Commission applies to people with mental illness. The patients that I see, they have a tremendous need for hope. They need some good news, and they look for it everywhere but the church. I wish the church could be a place where we could apply biblical principles to people who are struggling with life in a real, authentic way, so that people walk out knowing that God loves me. He will never leave me or forsake me, nor will His people, and that He truly loves me in the midst of my suffering. I have a term I use with my patients called redemptive suffering, that the suffering you go through, God can use to cause a larger good, but you have to go through the suffering to find it out. But I wish our churches were places of healing where people with mental illness would feel welcome and feel hope, the good news.
I just want to thank you each just for joining us today, but also sharing your wisdom, but also for what you do, for loving people and giving them hope and finding ways to help people take a step towards God where that was maybe very difficult to do so before interacting with you. So thank you for sharing that with us, and thank you for taking the time to teach all of us today.